Okay, we'll kick off. So good evening, tēnā koutou katoa. My name is Stephanie Valent. I'm an emergency medicine specialist up in Whangarei Hospital. And it is my pleasure to be kicking off tonight's webinar. Firstly, a huge thank you to those attending. Thank you for your support and your interest. Before we introduce our guest tonight, just a quick few words around the New Zealand Prehospital and Retrieval Medicine Society, and I'm just going to abbreviate that to FARM for tonight, as we hold its inaugural webinar before we welcome our guests in the Journal Club aspect of tonight. So the society has been born from what was a bit of a vacuum in this country for a space that brings together diverse professions and specialties to collaborate and advance the field of FARM in New Zealand. It's a collegial space to collaborate and share resources, ideas and direction. And I'm just going to read directly from our charter just to provide a little bit of context for those coming today, given this is our first session. So from our society charter, the purpose and objectives of what we're planning to do is to promote excellence, collaboration and education in the field of prehospital and retrieval medicine in Aotearoa, New Zealand. Specifically, the objectives of the society are to facilitate networking and collaboration among professionals involved in prehospital and retrieval medicine, to promote best practices and evidence-based approaches in FARM, to provide opportunities for interprofessional development, education and training in FARM, to support research and innovation in FARM, and to advocate for improved pre-hospital and retrieval medicine systems, resources and policies in New Zealand. You can refer to those at our website under our charter, which we can put the link into our chat in just a minute. I'm really pleased to announce that over just the very brief time we've existed, our membership has grown to represent clinicians across the motu, from Dunedin, West Coast, Christchurch, Hawke's Bay, Bay of Plenty, Auckland, and last but definitely not least, Whangarei, Northland, and further north as well. We also encompass several medical specialties with approximately 15% anaesthetics representation, 12% ICU, big chunk of emergency medicine, and 8% rural hospital, which is really exciting for me personally as well. For any non-members today, welcome, and please have a read of our charter on our website. If it resonates with you, I encourage you to sign up. And although we've started as a group of doctors, I especially encourage any paramedics or flight nurses in the audience to join up, as one of our key themes is inclusivity. So we want everyone's voice involved. As per our email, recently there's been a lot of interest in the Society's white paper, and I welcome you to email your feedback in. That email I will put on the chat in a minute as well. That's info@farm.nz. Today, though, we'll keep the focus on the paper by Lavery et al. And avoid detracting from that work. So with that, again, a huge welcome. I'd like to introduce our moderator today, who will then introduce our senior author for the paper. So Chris Denny, welcome tonight.
Sorry, all the buttons. I'm kind of Teams built and Zoom's on the upper side of the road. So kia ora and welcome. Again, my name's Chris. I can see, and there's a few too many things moving all at once, but I can see many of your names. And so if I can just again issue a huge welcome on behalf of this society. My job, I guess, as moderator is to lay out the rules of engagement. So they've written them down for me. The first is just, again, a reminder about respectful discussion. I think this is, albeit a controversial topic, but also one in which we all work together, depending on where you are in hospital, out of hospital, for retrievals, inter-hospitals, and pre-hospital missions. We really like to get a conversation happening. And so you should be able to see at the bottom along the horizontal, I guess, row of your screen, a chance to ask questions. So really actively encourage you to put questions into, I guess, this space. And then when Mike Christian's finished presenting his work, we'll be able to go questions and answers in the second part of this presentation. What else to tell you? because we all work for different organizations, some of us from multiple organizations, just to say that we're speaking in our personal capacity. So this is not to reflect the views of services or organizations that we work on. It's a webinar, I've told you that, so it runs more like a lecture, meaning we'll give the stage to Mike Christian in a minute, and he'll be able to present, and you should be able to hear and see what he's doing. Please, again, send questions through. And then what I'll do is at the end, I'll pose questions. So I'm going to now just deliver a very brief introduction so we can get into the thick of it. And that's the speaker. I invite him to join us when he can. And so Mike Christian is also a Canadian, and he and I went to medical school, not at the same time, but at the same university several years back. Mike originally was a paramedic and worked as a paramedic in the province of Ontario in Canada. I think what makes his background quite unique is he offers both a civilian and a military perspective, having served with the Canadian forces in Afghanistan. And he also brings an international perspective, having worked in Canada, Afghanistan, and the United Kingdom, sort of highlight countries. I think in terms of the perspective, he brings not only an active pre-hospital perspective, but also an in-hospital perspective, having trained in infectious diseases, intensive care medicine, military medicine, and then pre-hospital emergency medicine, or FEM, which is what they call it in the UK. But I think what makes Mike unique is his attention to research, innovation, and governance, as evidenced by the fact he serves as the chief safety officer at a large hospital in the province of Ontario, and has served in governance and research lead roles with London's Air Ambulance in the UK. I think the fact we've got some evidence to discuss, we're all aware that no evidence is perfect. What we're interested in is the best available evidence and a meta-analysis. And in fact, we think a journal club is a really important place to start. So I'm going to hand over the mic and the presentation to Mike. And I'd just like to thank him for making some time late this evening in British Columbia to present to us. Thanks, Mike.
Thanks, Chris. And just for you, can you confirm that you can see the, oops, sorry, let me just go back and make sure I have the sound sharing up. So you can just confirm you can see the slides.
Yeah, I confirm.
Okay.
I can see slides and I can hear you.
Great. Thanks so much for having me. It's a pleasure to join with you all. I'm just going to start with gratitude and humility, acknowledge that I have the honor and privilege as a settler to live, work, and play in the traditional and ancestral territories of the Squamish, Musqueam, and Coast Salish nations here in British Columbia, and I will continue on with the talk. Hopefully, hit the Q&A button if you have any questions, and Chris will get to those at the end. So also for the talk, I'll show this at the very end, so if you don't have time to catch it now, and it pops up a couple times, but this Google Drive has all the references for the talk on it, a few extra papers from some of the recent talks. So feel free to go there and you can get all the resources for the paper that we're talking about today and talking around, and a number of other resources. So what I hope to do in the next about 15 to 20 minutes is, first off, start with a little background. And Chris just asked me to sort of cover a little bit about why do a meta-analysis and what's that about in the first place. And then a little bit about just sort of to frame this, why we asked this question, why we're even looking at this ourselves. I'll quickly touch on the methods, how we did the study, the results, what we found, at least the key highlights of it, and then really bulk the time in sort of discussion, trying to wrap some context around this. And then the Q&A, hopefully we'll have a good 15 or so minutes, 10 minutes at the end to be able to get through some of your questions about this and comments and feedback. I've got some beautiful pictures of British Columbia scattered through here, so try and attract and woo a few people to come help and work with us here eventually. So you enjoy those. This is just a quick 2-minute presentation to try and just sort of frame what is a meta-analysis. I understand we have a diverse audience from clinicians, non-clinicians here potentially today, and some others. So just a little bit of level setting about what a meta-analysis is. Well, that's just a little bit about why meta-analysis. There's a great New England Journal video about meta-analysis, but it's about 6-7 minutes long and a little too long for this, but we can always share the link for that afterwards if you want more information. So why did we do this paper and why do we ask this question in the first place? So we're looking at and working with a group of people in British Columbia here to start a new not-for-profit charity to help support particularly rural remote areas in the province, but pre-hospital retrieval medicine across the province. And as part of that, we undertook an extensive literature review and search as one of the many pieces of inputs that went into the design of the organization. And this is one question from one area of that much broader horizon scan and literature review that we did. I hope some of you have heard of, but if not all of you, Peter Safar, he's one of my heroes from the past. He's often referred to as the father of many things, a father of CPR, father of paramedicine, particularly in the US, and father of critical care. And so he was one of the first founders of the Society of Critical Care Medicine and the original concepts of critical care. And he, in their initial definition, in the last point, they describe intensive care as including all the components of emergency critical and critical care medicine delivery system from pre-hospital and beyond. And really, we've spent the last 50 years of our time really focused, I think, almost exclusively on the beyond part, and as a system-centric and very non-patient focused aspect of medicine. We've really looked at all of the, how do we improve in-hospital care, mortality, et cetera, and a lot of people have forgotten the first part of that definition from the pre-hospital and beyond. And as I hope to show you in the next few minutes, that certainly that is, if we want to move the dial on potentially preventable deaths, particularly due to trauma, but a number of other things, the space in the area to really do that is in the pre-hospital setting. So I'm going to use the example of around trauma for this talk today, just because we only have a few minutes, but we can really go through the same example of where the bulk of the mortality is, where the biggest opportunities are to improve outcomes for whether it's MIs and out of hospital cardiac arrest particularly, but also things like stroke and OB and pediatric emergencies. And you can go through the list that there's a whole area of impact that can be achieved, and if we really want to move the needle on some of these conditions. So this is a paper that comes from a group from Houston, Texas, and this is a high-functioning, high-performance trauma system. And they looked at, well, why are patients still bleeding to death in what they call in their big city, and when are they dying? And as I mentioned a few minutes ago, the bulk, 55% in their study, and other studies, goes up to as high as 75% of patients that die from trauma now die in the pre-hospital setting. Once you make it to a facility, in most areas, certainly a major trauma center, the mortality rates are exceptionally small, and the ability to have any impact on decreasing those further, it gets to be quite difficult. The biggest potential for impact is really in that out of hospital and early phase of these conditions. John Holcomb and a group, this is the Miami group. They looked at their patient population, and again, I think there's a need. Certainly in Canada, we have sometimes too much of a pragmatism and a sense that, well, these patients are just going to die if they die pre-hospital anyways. There's not really anything you can do about that, and we really need to resist that sense. And in this study, they found 29%, so about a third of patients, pre-hospital deaths were actually potentially survivable, and mostly from chest injuries and hemorrhage, many of them non-compressible hemorrhage. And that one of the things this paper goes on to really talk about is the need for new novel pre-hospital interventions and much more advanced interventions to be able to stop and impact these deaths. John Holcomb and was involved in this study in his group. And again, a similar study, this one was in Houston, Texas again, and they found that of the pre-hospital deaths, they found 11% were potentially preventable in this case series they looked at. And again, these are really high functioning trauma systems where this is still happening, despite high volume of trauma, high performance pre-hospital systems, and really trying to minimize the on-scene time, et cetera, and impact that they can have on these patients. John's, who, if you haven't met him, he was a diehard trauma surgeon, a classic sort of person of just bring the patient to me, I shall fix them type of person. And he's really gone full, sort of done a 180 now and looked at, where can you really make the impact now that they've got sort of the in-hospital part of the trauma systems working so well. And he analyzed these two large cohorts from studies in the US and found that the peak time to death for severe truncal injury is 30 minutes, but actually the time it took to achieve definitive truncal hemorrhage control, again in these large US centers, was 2.5 or 2.1 hours. And that's certainly not uncommon for many different areas here in Canada and the UK even and elsewhere. And that he pointed out that by moving interventions into the pre-hospital setting, and particularly definitive hemorrhage control in the pre-hospital setting, you can have expected 78% decrease in the time to achieving that control as opposed to in-hospital. And that's really what certainly in London's Air Ambulance we look at doing, and many other high-performing trauma systems around the world now is taking at least a part of this in-hospital team and being able to move them and the interventions forward. And that's analogous to whether we're looking at, just yesterday, London Air Ambulance launched its pre-hospital ECMO program. They had a pilot trial that we did previously, and now it's moved into a regular part of practice. This is happening in places like Minnesota and other places across the US and elsewhere. And there is, you name the other interventions that you can start to really push to the left to make that, to start to have that impact. And you may ask, well, and certainly here in BC and I'm sure similar in New Zealand, well, how does this really apply to rural and remote areas? We're not in a big city. We're not 30 minutes from places. This is a different beast. But really, if you look at this curve, the mortality rate per hour is still high and doesn't actually really flatten out as a rate per hour until you get up to 9 hours. And we know in these rural and remote areas, sometimes, it can often take hours, 9 or more sometimes even get the patient to a major trauma center. So anything you can do to move those interventions to the left is going to have a huge impact for these patients, and in terms of trying to capture survivable, potentially preventable pre-hospital deaths. The other big reason we're really looking at is because we're really interested in trying to mitigate health inequalities in the system, particularly faced by rural and remote areas. This is both just for our rural and remote aspects of our province. Half of our GDP in British Columbia comes from the north half of our province, which has only a fraction of the population. But also, as a result of colonialism and all the things that happened with that, our Indigenous populations are generally also in more isolated, more northern parts of the province, and we have a duty to look at addressing health inequities in that group. So our motto of the MedResponse BC is focusing on the edge for the benefit of all. And this is really targeted care for the sickest of patients. And when we look at targeted care for sickness of patients, we're not interested in, it's not, good enough isn't sort of what we're aiming for, all right or okay, or, not worse than. What we're really aiming for to impact the health inequalities is really the right model to deliver the greatest impact to achieve the best outcome. So what is that model? And that's the question we're looking for. In terms of health inequities, sometimes, if you have a significant risk of health inequities because you're rural or whatnot, you really have to have high level impact to be able to overcome that. So our methods, it was a meta-analysis. The question we're really asking of this thing was, does implementing physician-led, and we can discuss that terminology, but interprofessional teams with physicians and others, whether they're nurses or paramedics, does that improve survival or reduce mortality? We looked at 2 different groups of studies for critically ill or injured patients, and we had exclusion criteria, and we really worked hard to separate that out from things like mode of transport. So we wanted to really look at the impact of the model, not the impact of other things, as best we could. In terms of the results, so we had a whole large number of papers, ended up with started with 2,296 papers, narrowed it down to 23 that met our inclusion/exclusion criteria, and that was just over 300,000 patients. And that's the other real benefit of doing a meta-analysis. In pre-hospital care, because we have such small numbers usually of these really sick patients, it's really hard for any group to get a population that can give you a good enough study in terms of patient size to get good accuracy and have narrow confidence intervals. We just published today a 20-year retrospective of thoracotomies in London, and it took 20 years to get 600 patients. And when you have small numbers, you have wide confidence intervals, which often means studies are found to be not statistically significant. So by doing a meta-analysis, we're able to combine lots of these studies together, get the numbers to be able to get a good statistical accuracy of what we're looking at. And this was from 10 countries. The high-level numbers that you've probably seen if you've read the paper already were from the papers that looked at mortality, where we used the original outcome that was in the paper. They had showed a 20% decrease in mortality across these various papers. More papers use survival as their outcome measure, and so we're able to subdivide that into out-of-hospital cardiac arrest or trauma, and that showed a 49% improvement with the interprofessional teams. So just sort of whip through a bit of the discussion about this. So the survival versus mortality, one of the biggest challenges is just a lack of standardized outcomes in general in this work. That makes it harder to combine studies, and one of the things we really need in this type of work in the future is to actually come up with a set of standardized outcomes for these papers. And in this, we decided rather than trying to do fancy math and risk some further errors or magnifying statistical anomalies that might be there, we decided to analyze them in the two groups that they already were. But a very smart, or smarter than me, colleague from Scotland, from EMRS in Scotland, an epidemiologist there, Ryan McHenry, this is just coming out as a comment on our paper. He redid the analysis, but did do that mathematical change, and reassuringly, he actually found pretty much the same thing, with overall a 41% increase in survival when you convert it all to survival for these patients. So it's just a nicer way to present the data, but also a second check on all the work that we did. Causality, we always like to think about. You can't actually answer causality from an observational study. But we can generate hypotheses, and that's what we did here. So some possible hypotheses as to why we found what we did. I do a deep dive into this in the pre-hospital care podcast. So it's an hour just on these topics. So I'll show this at the end as well. I'd recommend you go there. But just a couple of them quickly. So question, is this really a study about high-skilled, high education versus low-skilled and low education? I don't really think so. That's one of the reasons we chose the time frames we did, but all the papers except for one in the control arm had ALS. All of the ALS providers were highly educated, university level or equivalent in one center type of paramedics. And I think that's less of an issue in these papers compared to others. The other question that comes up, and when we think about, is this really just critical care versus ALS? And as an intensivist and a person who wants to push and see more pre-hospital critical care, I think we don't have nearly enough, either by ground or air, in most places in the world. My heart says I want that to be part of the answer, but my brain says, when I look at actually the studies that repeatedly, even up to a couple of weeks ago, another study coming out not showing that any of the specific interventions that were included in this type of cohorts at the time, such as intubation, RSI, and things like that, haven't really been shown to have significant mortality impacts. Sometimes a small amount, but certainly not the percentage of increase that we're seeing in mortality here. And a lot of the papers that were the studies that were included in the analysis that we did, because they're a little bit older, haven't started to really include things like Reboa, ECMO, thoracotomies. Even only a portion of them had blood products and things. So there's probably a little bit of impact there, but it's probably not the whole answer. And then that really left us with sort of this interprofessional teams effect, which is what really sort of jumped out at us as the large impact. And a recent paper from actually a colleague of yours in Auckland that looked at interprofessional teams across the world from different types of areas, from primary care through to critical care and ORs and things, found the simple fact of having interprofessional teams, they framed it as learning, but it's actually, as they say, 90% of the learning occurs while you're doing and working as an interprofessional team. That there's some magic in the mix there of bringing professions together to deliver care in healthcare, and certainly, and this is true in other different types of fields as well, that had an impact, and that showed a 28% decrease in mortality. So I think if you take that plus some of the potential benefit of critical care, that's probably where we're getting to the magnitude of some of what we've seen. If you really want to do more of a deep dive into the interprofessional teams work, I'd highly recommend reading Matthew Syed's Rebel Ideas. And really, I think a lot of this comes down to the idea of diversity. And it's not diversity diversity of gender and ethnicity, and those things are important. But what he really hones in on is diversity of thought, and people that really have been developed in thinking about problems and issues in different ways. And when you bring those together, particularly when it comes to decision making, and in areas like volatile, uncertain, complex, ambiguous environments, aka definitely describes pre-hospital care, you get better performance and better decision making. And a lot of this comes from doing things like breaking down information bubbles and echo chambers that can develop when you have a lot of people that are very the same approaching a problem. And that's all the way from training through to action and delivering. This slide is just to remind me to say that I think we're better together, and it's more than just the sum of the parts, but also to remind me that we've really been focusing on individual patients so far, and individual sort of team members and professions. And one of the things we really need to start looking at is the much broader picture, and not just at the individual level, but looking at outcomes at the team level, at the system level, and at sort of those broader levels. There are many other outcomes that we really need to focus on in addition to survival and mortality. And I always fall back on the quintuple aim, and we're about to publish some work on this. But there are tons of different things you can see from interprofessional teams in this type of pre-hospital setting that add value and have an impact that we need to start to look at and measure and have as some of those standard outcomes for these trials. Mortality and survival are important, but it's not just that. There's many more beyond that. Cost always does come up. It's the only one I'm going to take a minute to pick on now. And I think we really need to talk not about cost, but more about value. And value is defined as cost divided by quality divided by cost. And particularly quality can be broken down to impact and the ability to deliver that impact consistently. So the greater the impact, and in this case, the mortality benefit that we're seeing, and to be able to do that repeatedly leads to quality. So if you increase quality, even holding your costs the same, then value goes up. But if you are able to even decrease the costs, which we can see with some of these deployment models in this type of interprofessional teams, then you really increase the value, the bang for your buck that you get. And that certainly is, to me, starting up a charity matters a lot. In Scotland, they looked at this and did analysis with their startup and found that it meets the NICE criteria for the cost per quality adjusted life year. And there's a lot more details on this. Wales did a similar analysis, and as part of my MBA, I did a cost benefit analysis. And again, this type of interprofessional team came out as the more preferred in the cost benefit analysis. And we can always share some of that information later. So I'm going to end there because I think we're at the end of our 20 minutes, so I haven't seen Chris pop up yet. Two things. One, so St. Emlyn's has done an excellent and very, I think, rigorous critique and review of our paper and our work, and I certainly suggest that you go check that out. And then Owen Walker, who's a paramedic who from London, who is now runs a big podcast and certainly a leader in the world of paramedicine. He had me on his podcast and had a nice in-depth chat about the paper. And in the top left are the references. So Chris, I think hopefully you could hear all that and it went well. Let me know if you have any questions.
Oh, thanks, Mike. And there's a stack of questions I've been scribbling. So I've got 5 questions. Some of them are different people asking the same questions. First one is about what does it mean to target? And it says, with reference to the title of your research, when you talk about the targeted deployment of interprofessional doctor and paramedic teams, what does that look like, and how would you recommend systems target the sickest patients? Question mark.
Yeah, it's a great question. I think there's a very specific reason we included that targeted, because certainly in all the papers, it's not often written about as much, but this isn't, none of these papers or none of these systems deployed this as like the standard model for every patient. That doesn't make sense to me a lot. Certainly, if you look at some systems like Germany that do use models where they have many more physicians, they're moving. My friend Johannes, who's leading the Hamburg system there, they're moving more pendulum back towards the middle with increasing, and we're working with him to increase the scope and utility of paramedics in that field, because it's not efficient with what they have. And then we have other systems that have very few interprofessional teams, and we're trying to, the pendulum probably needs to move the other way in those services. And that targeted is really, and I think this is one of the areas that we really need to focus on for future research, and groups like London Air Ambulance and some of the other teams have done this already. But how do you identify those patients that are most likely to benefit from this, and not just the patients, but the services, the teams, and I think it's a broader group in that broader complex, because it doesn't, you want to find a balance. Dave Cooksley, who's another friend and colleague of mine from Australia, he always talks about, you probably want to aim for around 60 to 70% of patients where you really want to have those sick, high level of care required critically ill patients that you want to have these teams targeted at. But that's not the only thing you want them to do. You need about 30 to 40% of their patients where they're not like everything is absolutely, knife edge sort of critical, because you need to also have the time for the teams to build, to form the team structure, to practice their skill sets, their SEAM assessments, do all that stuff to get their functioning well, to be able to really be on sort of on point when necessary for those like seconds count kind of patients. So that's the blend there. And also, if you when you start to look at the broader rings of the quintuple aim of other benefits, certainly there's been jobs that I've gone to with London's Air Ambulance where it wasn't the clinical skills that on that particular patient, or the patient that benefited from that, but the team as a whole, some of the paramedics and first responders that we might have been coaching or mentoring, or even I remember a police officer who at the end of a debrief after a thoracotomy for an unfortunate person who had stabbed himself, that he had one of those door handle questions, and just as we're breaking up, puts his hand up. He's a brand new young officer, and he goes, did I make it worse by holding the patient down? And we were able to then have a debrief around the fact this patient was hypoxic, about to arrest. He was helping the paramedics hold him to get lines in and stuff, and that he absolutely did not kill this patient by doing this. But I'm certain that having that conversation and that reassurance we were able to give him at the end of that debrief allowed him to go home and sleep that night without, going on to develop whatever moral injury he might have otherwise had from that. So it's those broader things, but yeah, just to sort of say you have to target, but look at the broader benefits as well when you're thinking about targeting. Up, you're on mute, Chris.
Thank you for that. There's now a question. It's actually more about platform, and I appreciate you don't specify a platform. Many of the folks who are online tonight work for air ambulances, typically rotary wing, but there are some fixed wing providers as well. In the London experience, you might want to describe to the audience, but there's quite a balance of rotary wing and road. But the question was just, does this benefit, is it tied to the transport platform? Question mark.
Yeah, so we very carefully selected the papers to make sure that that they were not looking at the platform. There are some papers that just look at, they compare HEMS to ground service And then you really can't tell the difference how much of that is the effect of just rapid transport of a helicopter and getting further, maybe directly to an MTC as opposed to a community hospital and then having a secondary transfer. The papers that we looked at, most of the teams responded by dual methods. And a lot of times they would also return to hospital, not necessarily by air or by ground in the same way that they responded. So this really important question is something you have to separate out. And that's why it's been, when we narrow it down, there were only just, a smaller number of papers because we really wanted to try and eliminate that confounder to this piece of research.
Thank you. And again, I'll encourage, questions are still coming in. If it's the same question, I'll try and paraphrase it, but there's some excellent stuff, so please keep asking. Next one is, you asked a question about standardized, I beg your pardon, you said one of the challenges is a standardized outcome, and you mentioned there was a few different outcomes in the various papers. Somebody just said, hey, if you were to recommend a standardized outcome, what would that be? Or if there's more than one, that's fine as well.
And so my cheeky answer to that would be my recommended most important outcome would be to whatever matters to patients and families. And that's one of the things we don't necessarily ask. And one of the things we do need to ask more is, what really matters to the people that we're serving. And that includes patients, families, but the other providers that we're serving, whether it's retrieval work and that's the healthcare providers and system, or whether it's pre-hospital work and it's the other first responders type system. So that's sort of one thing to put in there. The second thing would be to say, whether you use survival or mortality, I think it doesn't matter, but certainly longer sort of 30-day and including in that, trying to also capture things like quality of life and those type of factors I think are also important. But what we're putting forward in the other paper that we're doing is really focusing on the quintuple aim, which is, for those not familiar, it includes patient outcomes like survival, quality outcomes, patient experience, quality outcomes, cost and financial outcomes, and health equity outcomes. So that we think it should be sort of at least a 5 kind of one from each type of approach would be the minimum outcome set.
Thank you. This next question, 3 different people have asked it, but it is the same question. Essentially, it says, do these results, are they generalizable to New Zealand? And then there's specific reference to your appendix where you describe some of the different paramedic skill sets in the various studies. And the question is, here in New Zealand, we have critical care paramedics with a broader scope of practice than many of the paramedics listed in the study. This scope is broader. In that case, are the results generalizable to New Zealand? Question mark.
Yeah, so 2 things. I'll tackle that last little bit first, and then I'll move on to sort of the broader part. So the scope question really gets down to, is this a study about critical care versus ALS? And so I think I answered that sort of bit, that there may be some effect of the critical care skill set versus the ALS skill set. But if you look at individual intervention studies, few of them actually show that for most of the interventions that are out there that are in the critical care skill set. Also, but I think there's probably hope since I practice critical care, there's some benefit there. It'd be difficult for me to put my hand on my heart and say that, yeah, that's counting for this whole big impact we're seeing. The second thing is that a lot of the skills that and the interventions that were required for these different types of patients, particularly in the out-of-hospital cardiac arrest ones and things like that, there weren't a lot that were beyond sort of the ALS type thing. So it's hard to really say that yeah, this is all just critical care versus ALS as causing that impact, and that would sort of apply to sort of the scope of practice piece. And so I think there is really much more about the composition of the team delivering those interventions that probably really has the bigger impact. In terms of the systems, so now that I'm getting sort of, although with Zoom it looks good, and I'm not as gray as I really am in real life, but with my very salt and peppered gray hair now, and the more time that I've spent working around the world, talking to people around the world in different systems, if you go into a crew room of almost any air ambulance base or air base and you start to say, what's going on? Tell me about your patients. Tell me about what you're seeing. Tell me about your challenges. It's the amount of similarity from place to place around the world is just, I find, striking. I could be, you sit there, you listen to these stories like this is just like home. This is just like the same things we're facing, the same challenges, the same issues. And over time, I think there is more similarities and commonality about pre-hospital care around the world, and patients are essentially the same in many of these places. And people might wear different color uniforms, they might have slightly different titles and stuff like that, get there in different ways. But also the interventions that are being delivered in general are quite similar. The patients are similar. I think there's a lot of generalizability from these studies. I get that question asked all the time too, because none of the studies were done in Canada here. And it is generalizable here. And I think, yes, it really is. But I would definitely encourage, one of the things we need to see is people need to be studying this in their own place and showing the data. And if not studying, even having a learning health system that has transparent collection of data, reporting of data, and using it to drive system improvements. And that we need to have that in all these areas, and we need to really combine as pre-hospital communities this data, because everyone only has small numbers, so we can actually start to improve the quality of research that's done pre-hospitally.
Thank you. Do you have energy for a couple more questions? There's about 3 more.
Yep. Do you have time?
Blend it. So this one, it says there are different specialties within pre-hospital and retrieval medicine, or FEM, in the UK. Is there anything in the research or what you read suggests that there is one specialty better than the other? So that's the first part of the question. And the second is, should people work full-time pre-hospital or maintain hospital practice, or could be ground ambulance practice, to maintain clinical, basically just say case mix?
Yeah, so I think in the last one, I'm a firm believer, and I think working, and this is one of the, I think that is one of the advantages that's conferred to physicians that work in pre-hospital care, is the ability to actually work in both areas and see that whole patient journey. Because there's so much of, even if it's not a single patient, there's so much you learn from seeing something in the early stage of pre-hospital care, making an assessment, making a decision, delivering an intervention, and then understanding how that plays out down the road in the patient's journey. That's essential to learning as humans, and how so many of us learn, and understanding that whole patient journey, and also understanding how what you do now is going to influence what might happen down the road, in terms of care delivered now, and your decision to intubate a patient, and what happens down the road with VAPs and ICU and other things like that. Like, all those things are important. And that's why I advocate both for physicians, but also, interestingly, and this is what I think is really the benefit of what we're seeing in the UK and elsewhere, of having more interprofessional teams working in both settings. I think there's a need for more interprofessional practice, and what's particularly paramedics inside hospital settings as well, to get those greater exposures, and working in critical care units and other things, and being able to take that back and forth. Certainly one of the benefits of doing that, and this is where some of the cost implications and other things occur, is that the ability to deliver a lot of these procedures, particularly when you start to talk about the endovascular stuff, whether it's Roboa or ECMO and those types of high-end procedures, the ability to do that on a much more high volume basis in the hospital setting, and take the skill set, once you develop it into the much more austere environment, really gives an edge both on performance of those procedures, but also in terms of decreasing training costs and whatnot, and the ability to be able to have a system that's sustainable for doing those types of high-end procedures outside of a hospital setting. In terms of specialties, so we're going to talk about specialties, not professions, but whether it's emergency medicine, anesthesia, surgery, et cetera, what we have in the UK in FEM. So we also have that same sort of variety of specialties in critical care, and certainly in Canada. And I think it's one of the things that makes us strongest. And one of the things, certainly if you go back to that, Matthew Syed's work around diversity and the benefit of that, you see this hugely in London, both between having different professions, the physicians and paramedics working together, developing the interventions that we've developed at London's Air Ambulance, but also with a variety of specialists in a team. I think it's better for patients. Like, honestly, if I'm a patient, and I used to use this all the time in the military when I was training people before they went out to FOBs and stuff in Afghanistan, I would, I used to chastise them when we would do simulations, and I'd come out and see one person at the end of the simulation sweating, covered in sweat. They've been, worse, the one leading the team, working their brain, thinking about this, and the others coming out, giving high fives and stuff like that. I'm like, no, this patient's sick and dying. They deserve everyone's brain working at its maximum to save their life. And I'd like that diversity and that different perspectives and thought, because that's, I think, how you get really the richness of care that can make a difference in these cases.
Thank you. And I'm going to bring Steph up in a minute just to close this off. I just want to make sure I'm scanning. There's been some superb questions. This is, I suppose, looking to the future, and just says, the person acknowledges no research is perfect, says, but where would you recommend the pre-hospital community, not specified, but go from here in trying to explore and answer these questions of workforce and crew configuration? So I guess what do you advise for the future?
Yeah, I think, and I touched on this a little bit already in terms of outcomes, but I think it's important we don't spend too much time looking inwards and sort of, focus on ourselves, and especially going too deep into, micro nuancing of crew configuration and whatnot. I think I'd take some of the big picture messages from this, some of the research about this and elsewhere about just interprofessional teams and the true strength and benefit of them, which I think is really, increasingly hard to and incontrovertible, but I would really say, so first thing is I'd say, what matters to patients and families, and make sure that our outcomes and the research that we're doing is important to them. That's, one of the best practices now, and we really need to have patient public involvement in our research and driving that. And then say, how do we really operationalize this? How do we say, okay, how do you focus on targeting, and not just targeting so you don't over triage, but targeting so we aren't missing the patients that we can really help. And, how do you actually pick up those cases? How do you identify them? I think there's a whole realm for AI and helping decision making and stuff like that for identifying those cases. Even the stuff that we've heard from colleagues like Good Sam, which I know is used a lot across Australia, anticipate in New Zealand as well, adding in the video components and all that kind of stuff. How can we improve our decision making? How can we improve our detection? And then looking at, how do we really, bring some of these interventions forward in a sustainable way? Because, the stuff that we're seeing, the early figures coming out from pre-hospital ECMO and some of these patients, it's like transformational in these patients. And a sneak preview, but the draft version of the next version of ILCOR guidelines actually has a recommendation for pre-hospital critical care as part of the core component of the cardiac arrest response. So I think we're probably going to be seeing more of this coming forward. So how do we do it? How do we make it cost effective? How do we have the best impact on patients in doing this? And how do we look at that broader set of outcomes across the quintuple aim?
Last question, and I'll hand it over to Steph. You may just choose to not answer because it's a tricky one. It says, interprofessional teams should mean that everyone on this call has a role to play.
Yep.
What are the barriers? It seems that ego is one as to why we can't work well together. By the way, this exists in the hospital as well as out of the hospital. But are there any lessons, I guess, from different parts of the world you might be able to share as we confront that cultural challenge?
Yeah, so I think there's a variety of reasons why some of the interprofessional challenges. Some of it is some of the nihilism I mentioned about, people just think about, oh, they're going to die anyways, it's pre-hospital, and they don't invest in that. That's a challenge for everybody. It's not just interprofessional teams. There's a respect issue, I think, for pre-hospital care. I don't know what it's like in New Zealand, but even in London, as a pre-hospital physician, and certainly as paramedics there, I know that there's this, other professions, view that work in pre-hospital care is not necessarily as valuable sometimes, or, the whole just, whether it's just bring them to the hospital, sort of a pat on the head kind of thing. And and whatever is part of that. So there's that to overcome. And then I think there's culture pieces, which are challenging. And I reflect on where we were in medicine. Certainly when you and I first started, Chris, and even before us with behaviors that nowadays would absolutely not be tolerated amongst physicians. I think interprofessional practice, particularly in critical care, but emergency medicine, pretty much everywhere in medicine, is the expected standard that you have to be able to be involved in. And whether it's through the selection of people, through medical students as they come forward, or as well as the self-regulation of the profession, saying your behavior is throwing scalpels at people, whatever, things like that is not tolerated. And we've removed our colleagues from the field when they've done that. I think there's some lessons for sort of the still evolving profession of paramedicine to say, okay, well, how do you self-regulate? How do you manage, this introduction of interprofessional practice both ways, and ensuring that people are given the respect that they need from other professions, but also within their own colleagues, that sort of is reciprocated and embraced.
Thanks, Mike. I'm going to hand it over now to Steph Valent, but I suppose obviously we can't see and wave and clap, but just want to acknowledge the immense amount of work that you're putting into answering these questions. So I want to thank you for your time. Steph,
thanks for having me.
Awesome. I just wanted to talk with that, Chris. A huge thank you to Mike for joining us tonight and sharing his wealth of knowledge in this research, the surrounding research, and in the general area of farm. So it's been really valuable. Massive thank you to all our participants, and some really good questions sent in to stimulate that discussion. So thank you for that.